Hello everyone. In this class, we'll try to learn about jugular venous pulse and heart sounds. The learning objectives of this class would be to name the waves of JVP and give their causes, give the causes, character and significance of heart sounds. Pressure change in atrium is directly reflected in internal jugular veins. So there are different waves of JVPs, that is jugular venous pulse. It has 5 waves, 3 positive waves and 2 negative waves, that is ascents and descents. The positive waves are A, C and V waves, and the 2 descents, that is negative waves, are X and Y. The C wave is due to the atrial contraction, and C wave is the wave which coincides with the onset of ventricular systole and results from bulging of tricuspid wall ring into the right atrium as the right ventricle pressure rises. And V wave, it indicates the passive rise in the pressure in the right atrium as venous return continues, while the tricuspid wave remains the tricuspid wall remains closed. And X descent is caused by the fall of right atrial pressure due to the relaxation of the right atrium, whereas Y descent is due to the fall in the right atrial pressure when blood enters into the right ventricle as tricuspid wall opens. So here this diagram shows the different positive waves, that is A, C, V, and the negative waves X and Y, which corresponds with the systole and diastole of the cardiac cycle and the different heart sounds, that is S1, S2 and S3. Abnormal JVP waves, the conditions wherein there is a raised JVP, that is it can happen in right-sided heart failure if there is obstruction of the superior vena cava, or if there is any increase in the circulating blood volume because of the pregnancy or acute nephritis, or over enthusiastic treatment with IV fluids. It can also occur with congestive heart failure, constrictive pericarditis and tricuspid incompetence. The prominent wave A wave is seen in pulmonary stenosis, pulmonary hypertension, tricuspid stenosis, uh, and also it can be seen in myxoma of the right atrium and the distended right atrium in atrial septal defect, and it can also be seen with the cardiomyopathy. The physiological basis for the prominent A wave occurs due to the increase in the force of right atrial contraction associated with right atrial hypertrophy or hypertrophy of right ventricle. When right atrium contracts against the increased resistance, prominent A wave occurs. Canon wave, where amplitude of A wave is abnormally big, and this is called as giant A wave or Canon wave. It occurs when right atrium contracts against closed tricuspid wall. The Canon wave is seen in complete heart block when atrial and ventricular systoles coincide. It is also seen in nodal rhythm when the right atrium and ventricle are activated simultaneously. Absence of A wave can be seen in atrial fibrillation. The prominent V wave is seen in tricuspid regurgitation because when ventricles contract during systole, the blood enters into the right atrium through the incompetent tricuspid wall. So this diagram showing abnormal A wave, that is very tall A wave, which is called as giant wave or Canon wave. Coming to the heart sounds, there are first heart sound, second heart sound and third heart sound and fourth heart sound as well. S1 and S2 are heard normally by stethoscope. The first heart sound represents the beginning of the systole. The causes of it occurs because of the vibration set up by the sudden closure of the AV wall and rapid increase in tension in the ventricular muscles during isometric contraction acting on filled ventricles. And it also occurs because of the turbulence created in the blood due to the ventricular contraction. The duration of the first heart sound is 0.15 second the frequency ranges between 25 to 45 hertz, and it is a soft sound heard as a lub. It signifies the beginning of the ventricular systole and the AV wall closure. Accentuation of the first heart sound occurs in exercise, hyperkinetic circulatory states like anemia, beriberi, uh, and it also can happen in hypertension. Diminution of first heart sound occurs in shock, acute myocardial infarction, constrictive pericarditis, and also it is seen in pericardial effusion, cardiomyopathy in advanced stages, also in obesity and in emphysema. The first heart sound has two components, the mitral and tricuspid components. The mitral wall closes slightly before tricuspid wall. This gives rise a splitting of the first heart sound. But normally this splitting cannot be detected by auscultation because both of the components are very low pitched and merge into each other. Therefore, audible splitting of the first heart sound is always considered as pathological. Second heart sound. The cause of the second heart sound uh, is primarily due to the closure of semilunar walls, and also because of the rush of blood into the ventricles due to the opening of the AV walls, which also contributes. The duration of the second heart sound is about the 0.12 second, the frequency at around 50 hertz, and it is usually heard as a dub. The, sec- the second heart sound signifies the end of the clinical systole and closure of semilunar walls. The loud A2 uh, aortic component occurs with a systemic hypertension and aortic dilatation. Diminished A2 occurs in aortic stenosis and aortic incompetence. And loud P2, that is pulmonary component, is going to occur in pulmonary hypertension and pulmonary artery dilatation, whereas diminished P2 occurs in pulmonary stenosis. The splitting of the second heart sound is due to the gap between the aortic and pulmonary components. It is easy to detect because sounds of aortic and pulmonary wall closure are high pitched and can be separated. The splitting of the second heart sound is due to the separation between the closure of aortic and pulmonary walls. The splitting is distinctly heard during inspiration. During inspiration, more blood is drawn into thorax. Therefore, venous return to the right atrium increases and right ventricular stroke volume increases. This increases the duration of right ventricular systole. Thus, P2 is slightly delayed. Also during inspiration, left ventricular stroke volume decreases because of blood is pooled in the dilated pulmonary vessels and dilated left atrium, which occurs due to the increased negative intrathoracic pressure. Therefore, left ventricular systole is shortened and A2 arrives earlier. Thus, during inspiration, A2 occurs earlier and P2 occurs later. Hence, splitting of the second heart sound widens during inspiration, and opposite mechanisms operate during expiration and splitting narrows. When pulmonary wall closes earlier to aortic wall closure, this condition is called as reverse splitting. This occurs when the left ventricle takes more time to empty than the right ventricle. So it is seen with the left bundle branch block, that is LBBB, and left ventricular failure. The third heart sound is usually heard in conditions in which circulation becomes hyperkinetic. The third heart sound can arise from either side of the heart, but usually it arises from in the left ventricle. The causes are it is caused by the vibration set up in the ventricles during the early period of the rapid ventricular filling. The rebound fencing of the cusp of the wall and chordae of the respective wall due to the vigorous elongation of the ventricle caused by the rapid inflow of blood also is the cause for third heart sound. The duration is 0.1 second. It is a low pitched sound and it is best heard in the mitral area. The significance of third heart sound is it is attributed to the rapid ventricular filling. It is heard in diseases in which the mitral diastolic flow is increased. In heart failure, atrial pressure is increased, and in early filling of the ventricle is rapid. It may be heard shortly after myocardial infarction or in diseases where distensibility of the ventricular muscle is altered. The sound arises from the vibrations in the atrioventricular wall structures and in the ventricular muscle. The fourth heart sound is also called as atrial sound as it is produced during atrial contraction. The presence of the fourth heart sound is always considered as abnormal. The cause of the fourth heart sound is it is caused by the atrial contraction, and it is produced by the vibration set up within the ventricle due to the inflow of blood produced by atrial systole. It is a low pitched sound. It occurs just before the first heart sound, that is late in the diastole. It always indicates the fourth heart sound. It always indicates that an increased stiffness or non-compliance of the ventricles. It is heard in the left ventricle hypertrophy due to hypertension, myocardial infarction, pulmonary embolism, and pulmonary hypertension. Triple heart sound. This consists of three heart sounds. The first, second heart sounds, and the third sound can be either the third or fourth heart sound. When the heart rate increases more than 100 per minute, the triple rhythm is called as gallop rhythm because it produces a typical cadence of gallop of a horse. The individual sounds cannot be identified separately. If the gallop is due to the third heart sound, it is called protodiastolic gallop, or if it is due to the fourth heart sound, it is called as presystolic gallop. Murmurs are due to the turbulence in the blood flow. The site of origin of these murmurs is the point of maximum intensity and usually indicates its site of origin. Depending on the timing of the murmurs can be classified into systolic, diastolic, or continuous murmurs. Depending on duration, it may be early diastolic, mid diastolic, early systolic, or pansystolic. The murmur may be soft blowing, or it can be harsh, rough, and rumbling. The loud and rough murmurs are usually associated with organic valvular and congenital lesions. Radiation or conduction. From the site of maximum intensity, the auscultation is performed in different directions to detect whether the murmur is localized or conducted to other parts. During inspiration, the stroke volume of the right ventricle increases while that of left ventricle decreases. Therefore, any murmur becoming loud during inspiration is considered to originate from the right ventricle, and any murmur increasing increasing during expiration is attributed to the originate from the left side of the heart. So this is in brief about JVP and the heart sound. Thank you.